Dear colleagues, dear students, I congratulate you on the start of the academic year, and I hope that all are healthy. Welcome to everyone for my lecture. Last week you get your first lecture from nervous system with Dinara ma'am about pathophysiology of pain, and this lecture topic is pathophysiology of cerebral edema. I am a teacher at the Department of Pathological Physiology. I believe Dalita. Let's start our lecture. In this lecture, we will talk about cerebral edema, general causes of the development of cerebral edema, classification. We will talk about 5 types of cerebral edema, pathogenesis of each cases, general clinical manifestations of cerebral edema, and about principles of therapy. What is a cerebral edema? The most basic definition of cerebral edema is swelling of the brain. It is a relatively common phenomenon with numerous etiologies. It is a serious and life-threatening condition that occurs as a result of fluid accumulating inside the brain, which increases the size of the brain. Because the brain is confined to the cranial box, so any increase in the volume of fluid inside the brain raises intracranial pressure, which reduces blood flow to the brain and weakens the supply of the brain with oxygen. Cerebral edema is sometimes difficult to treat and leads to permanent damage. Let's talk about causes of cerebral edema. Causes of cerebral edema. General causes of cerebral edema we divide to 2 types. They are neurological causes and non-neurological causes. Neurological causes include brain injury, ischemic stroke, brain hemorrhage, infections, brain tumors, etc. Brain injuries such as direct hits to the head may cause damage to the brain. Severe injuries can lead to fractures of the skull bones. The bone fragments resulting from the fractures may lead to a rupture of the blood vessels, leading to cerebral edema. Some cases of stroke lead to the occurrence of edema, especially if the cause of a stroke is a decrease in the amount of oxygen delivered to the brain, which leads to the death of the brain cells and swelling as a result of the injury. Brain hemorrhage. A brain hemorrhage is a type of stroke that occurs when the blood vessels in the brain rupture and leak. This leads to bleeding in or around the brain and causes inflammation and an increase in intracranial pressure. Infections. Some bacteria are able to cause inflammation and swelling in the brain, especially if left untreated. Brain tumors. The presence of tumors creates additional pressure on the brain, causing swelling. Other causes of cerebral edema. Other causes such as carbon monoxide poisoning, common hiking injuries, venomous animal bites, viral infections, and some medications. Next type of causes are non-neurological causes, which include diabetic ketoacidosis, lactic acidotic coma, malignant hypertension, hypertensive encephalopathy, fulminant viral hepatitis, hepatic encephalopathy, Reyes syndrome, systemic poisoning, carbon monoxide and lead, hyponatremia, opioid drug abuse and dependence, height altitude cerebral edema. Classification. Based on pathogenesis, we divide five types of cerebral edema. The most common type of cerebral edema is vasogenic cerebral edema. In second place, cytotoxic, or also known as cellular edema. Third one is interstitial, also called hydrocephalic edema. Osmotic cerebral edema, which also called hypostatic edema. And the last one is hydrostatic cerebral edema. Let's talk about each type of cerebral edema. First one is cytotoxic cerebral edema. In this case, as the name says, occurs intoxication of the neurons. Causes of cytotoxic cerebral edema are various toxins, including nitrophenol, hexychlorophene, and isoniazid. It can occur in Reyes syndrome, severe hypothermia, early ischemia, encephalopathy, early stroke or hypoxia, cardiac arrest, and pseudotumor cerebri. Pathogenesis. In cytotoxic edema, the blood-brain barrier remains intact. Brain insults induce intracellular ATP depletion, resulting in mitochondrial dysfunction and oxidative stress. These events cause a disturbance of intra-extracellular ion balance. As a result, excessive inflow of extracellular fluid and sodium into cells are induced, leading to cell swelling. Because the extracellular sodium contents are decreased by excessive inflow into cells, the outflow of sodium and fluid from blood vessels is compensatorily accelerated. The intravascular sodium outflow results in extracellular fluid accumulation in the cerebral parenchyma. Swollen astrocytes occur in gray and white matter. These interfere with neuronal and oligodendrocyte function. This edema occurs through intracellular hyperosmolarity and extracellular hypertonicity with deranged ATP-dependent sodium-potassium pump. Next type of cerebral edema is vasogenic edema. Vasogenic edema is most common case of the cerebral edema. Causes of vasogenic edema are trauma, tumors, focal inflammation, late stages of cerebral ischemia, and hypertensive encephalopathy. Pathogenesis of vasogenic edema. After brain injuries, endothelial tight junctions are disrupted by inflammatory reactions and oxidative stress. Moreover, activated glial cells release vascular permeability factors and inflammatory factors, and these factors accelerate blood-brain barrier hyperpermeability take place. These events cause extravasation of fluid and albumin, leading to extracellular accumulation of fluid into the cerebral parenchyma. As water enters white matter, it moves extracellularly along fiber tracts and can also affect the gray matter. In this slide, you can see pathogenesis of vasogenic edema and cytotoxic edema. As we talked before, in vasogenic edema occurs damage of tight junctions, which leads increase of permeability. Due to high permeability of vessels, from the blood into the intercellular space occurs leak of albumin's positive ions, which lead accumulation of the water in intracellular space. While in cytotoxic edema, tight junctions is intact, but here mainly occurs dysfunction of the sodium-potassium pump, which lead accumulation of sodium and water inside of the cells. Here you can see morphological difference between cytotoxic brain edema and vasogenic brain edema. In cytotoxic brain edema, you can see edematous neurons, edematous capillary endothelial cells, edematous astrocytes. While in vasogenic brain edema, these changes is not occur. But in vasogenic brain edema, we have rupture of the blood-brain barrier, while in cytotoxic brain edema, blood-brain barrier is intact. In cytotoxic edema, influx of fluid inside the brain cells take place. In vasogenic edema, influx of fluid into the interstitial space take place. Next type of cerebral edema is hydrostatic edema. Main causes are accelerated hypertension, mountain sickness, nitric oxide. Pathogenesis. This form of cerebral edema is seen in acute malignant hypertension when systolic blood pressure is more than 160. It is thought to result from direct transmission of pressure to cerebral capillaries, with transudation of fluid from the capillaries into extravascular compartment. Occurs interendothelially and transendothelially. Then can transcend opening of blood-brain barrier. Later, extracellular protein osmotic gradient draws fluid from vascular compartment. Fourth type of cerebral edema is osmotic edema. Causes of osmotic cerebral edema is rapid reduction of blood glucose in hyperosmolar hyperglycemic state, overproduction of antidiuretic hormone, infusion of hypotonic solutions, drowning in fresh water, renal failure, liver failure accompanied by a decrease in osmotic blood pressure. Plasma can be diluted by several mechanisms including excessive water intake or hyponatremia. Pathogenesis of osmotic edema. Osmotic edema occurs as a result of a loss of osmotic balance between the blood plasma and the visceral tissue of the brain, which promotes the accumulation of fluid within the brain. Normally, osmotic pressure of cerebrospinal fluid and the extracellular fluid in the brain is slightly lower than that of plasma. Plasma dilution decreases serum osmolarity, resulting in a higher osmolarity in the brain compared to the serum. Blood-brain barrier is relatively intact. Then edema is interstitial in location. Last type of cerebral edema is interstitial cerebral edema. First of all, we should talk about cerebrospinal fluid. As you know, cerebrospinal fluid is a clear, colorless liquid around your brain and spinal cord. Cerebrospinal fluid is a total volume of about 150 ml running in cavities inside chambers and around the brain and spinal cord in cisterna subarachnoidalis. Cerebrospinal fluid helps protect the brain from shock in regulating metabolic activity and removing exudate. The fluid is absorbed in the upper area of the brain surface into the vast sinuses. Through microscopic villi call it arachnoid villi. The delicate balance between fluid production on the one hand and its absorption on the other hand maintains its constant quantity. So interstitial cerebral edema occurs especially around the lateral ventricles when an increase in intravascular pressure causes an abnormal flow of fluid from the intraventricular cerebrospinal fluid across the ependymal lining to the periventricular white matter. And this edema takes place in obstructive hydrocephalus due to a rupture of the cerebrospinal fluid brain barrier. This results in transependymal flow in cerebrospinal fluid, causing cerebrospinal fluid to penetrate the brain and spread to the extracellular spaces and the white matter. In this slide, you can see difference between types of cerebral edema. For example, in cytotoxic cerebral edema occurs a rupture of cellular metabolism. In vasogenic edema, take place breakdown of blood-brain barrier. In interstitial cerebrospinal fluid leak. In osmotic edema occurs difference osmotic pressure between brain tissue and the blood plasma. In hydrostatic occurs increased hydrostatic pressure of the brain vessels. Also here you can see a morphological difference. For example, in cytotoxic occurs cell swelling, in vasogenic increased capillary permeability, in osmotic decreased blood osmolarity, in interstitial have hydrocephalus, in hydrostatic have malignant hypertension. Then you can see location in cytotoxic gray and white matter, in vasogenic only white matter, in interstitial periventricular white matter, in osmotic edema is located in white matter, and hydrostatic also in white matter. Also you can see a level of extracellular fluid. Here only in cytotoxic brain edema occurs decrease of extracellular fluid. Why? Because occurs intracellular accumulation of the fluid. And blood-brain barrier is only in vasogenic edema disturbed. And the effects of treatment, you can see steroid hormones effective only in vasogenic cerebral edema, and effect of diuretic hormones are effective in cytotoxic, interstitial, and hydrostatic edema. Clinical features. Symptoms of cerebral edema vary depending on the severity of the edema and the underlying cause, and are manifested by the following symptoms: headache, dizziness, nausea, vomiting, numbness, loss of muscle nerve coordination. In severe cases, symptoms such as mood changes, memory loss, loss of sight, low heart rate, high blood pressure, difficulty speaking, difficulty moving, pain in the neck, reflex urination, unconscious, epileptic seizures. Principles of treatment of cerebral edema. As we know from the course of general pathophysiology, there are three main principles: etiatropic treatment, pathogenetic treatment, and symptomatic treatment. Etiatropic treatment means identification, elimination of the root cause of edema. Pathogenetic treatment, for example, removal of excess fluid, normalization of metabolism, normalization of blood osmolarity. And the last principle is symptomatic treatment, relief from accompanying symptoms. If you have any questions, you can write in the comments. Thanks for your attention.